I'm gonna go ahead and video ours so it helps if we want to share some of this on future Facebook videos and things like that, just for people to know. And it also helps with staff training and when our other staff do these workshops too. So if it's okay with you, we'll get started. Steve and I will go ahead and take our masks off so that you can see our faces and get to know us. You kind of mentioned, you joked and said, well, I think I saw your face on Facebook in some of those videos. So I've been blessed to be the one that they push out in front of the camera sometimes. I'm not usually too camera shy to be the face, but I'm Michelle Sierra, physical therapist here at Dynamic Physical Therapy. I'm one of the owners and founders, but it wouldn't be for my husband, Steve. There would not be a Dynamic Physical Therapy because he's the one that had the vision and the dream 21 years ago now. Yeah. So we'll tell you a little bit more about us, and this is kind of a nice time because we've been doing these workshops since about June of last year, I would say, focused on the rotator cuff, and the very first one we got to do together, and this is the first one we're doing again together, so it's kind of a nice time for us. So appreciate all of you guys coming out in the beautiful sunshine weather. We hope to teach you a little bit about the rotator cuff tonight. Do you want to ask them a little bit, and I'll take notes for you? I know you know some of these faces, but kind of ask.
So we'd like to start off with just knowing a little bit more about you guys and what brings you up here. You know, part of what we do is very specific to you guys. So it's interesting as we've done these workshops over the last year to realize the commonalities, not to mention what we see in the clinic, the commonalities. So I think you guys would be surprised at the commonalities between your symptoms. Anybody want to share a little bit about their symptoms, maybe which shoulders bother them, and a little bit about
We'll start with your first name, whoever wants to go first.
I'll go.
Yes, sir.
My name is Ben Roberts, and I don't know what I did. I just do stuff that I shouldn't. And one day my shoulder started hurting real bad, and then I didn't help it but stop. And I was standing on the ladder cutting crazy with a chainsaw above my head.
Oh, wow.
And that's when it really started to hurt.
Which shoulder?
My right shoulder.
Your right shoulder.
And
Okay.
then I went to orthopedic surgeon, and he did X-ray, told me I had a tear, but it wasn't bad. And he says, why don't you go try physical therapy, and he gave me the name, and that's why I came. So.
Okay. Good.
And I've been coming for a while. I've seen you several times here and stuff. So.
Yeah.
But everybody is. If my shoulder doesn't feel any worse than it does now, I will not have the surgery.
Wow.
So
Awesome.
they've helped me a lot.
Awesome.
I've come in here sometime. And
Awesome. We didn't pay him to say that either.
no, but I do say this. I do say this much. I get fussed at every day.
Well, it's funny, I had a past patient show up to one of these, and I hadn't seen her in years since we were at other facility, and she had both shoulders operated on, and I saw her in the audience, and after I said, what's going on, why are you here? And she said, I just wanted to come, I hadn't seen a new place, I wanted to see. And I said, okay, well, you've already been through therapy, you know, was it helpful? And she said, oh my gosh, yes. And we kind of think that we're preaching these things all day long, and we do, but it's a journey for every patient, and sometimes just hearing it a different time or a different way, you take home a little bit more and you understand it a little better.
Yeah.
No, but I really, the people that work here, everybody's fantastic. And again, I'll take cash this time. I don't have to check it all, but no.
Well, thank you.
Anybody else want to volunteer a little bit about them? Yeah. Let's start off around. Yeah, we'll start right in the front.
John Trigg.
Mr. John. Yeah.
I had a total, dislocation, torn all the ligaments, tore the collarbone out of the joint, and had that repaired. Then I've had it replaced,
Okay.
and I'm a mess. I've had 4 total knee replacements.
Oh, jeez.
There's,
Yeah.
We call you orthopedic surgeon's dream.
I
Is it
have
the
9,
shoulder?
You've put a few kids
3
through school.
ACLs,
Yeah.
4 arthros, ACLs, you name it, I've had it.
It's primarily your right shoulder now.
Right shoulder.
Right shoulder. Okay.
And I believe that the rotator's torn again.
Okay. Okay.
And one thing I didn't get, what would you say your pain level is? 0 out of 10 with 0?
Depends on what I'm doing. If I raise my arm, it's about a 9, makes my eyes water.
Okay.
And Glenn, what about you? What was your average pain level here?
6.
Okay.
Okay. Yeah.
I'm
Mrs.
Dennis. Back in high school, college, I had 2 broken elbows and a broken arm up here, the humerus,
Yeah.
from sports. Well, the trauma on the shoulder each time falling, you know, really tore it up. So the doctor suggested I don't do push-ups So I get drafted in the Army, and in basic, all we did was monkey bars. And, I would do the minimum 18 or whatever it was, and then drop off, and the pain was just awful.
Yeah.
Well, it didn't really bother me till a few years ago, I guess over time, 30, 40 years.
Right.
So it's just a low-grade pain level, like 2, not even a 3, just low-grade discomfort.
Sure.
But when I go to reach, I have this nerve pain will shoot through like somebody's
Yeah.
jabbed a needle in me,
Right.
and I just have to crumple up.
Right. And Mr. Dennis is an interesting case too, and,
Very interesting, that's what.
yeah, well, well, and I see him in the gym and I see him working, and that's why I'll use you, Mr. Dennis, it's okay with you as an example, no personal information
Well, yeah,
shared.
example, huh?
Yeah, but the idea that I see him in the gym and I see him working, and we'll bring up that point later in this conversation, and I think but important, we'll circle back.
Something I'm doing wrong?
No, well, not so much what you're doing wrong, but just the fact of you trying, and sometimes just trying, whether you go to Google, look at some of that, I don't want to get ahead of ourselves, but there's a lot of solutions out there potentially, or, we're motivated people and we want to help ourselves, but sometimes despite our best efforts, there's some things that's just really specific and critical, and we'll talk more about that in the direction and what it takes to get a shoulder better. Anybody else?
William, I guess my pain level is probably around 5, 6, and it's more of a numbing type pain. It's my left shoulder. Haven't really done anything that I can think of other than I sleep on my side and I sleep on my left shoulder when I'm sleeping on the side. I use my left hand to hold my iPad when I'm working and that kind of stuff, and the weight of the iPad and the position and all that. And also I drive with my elbow up out of the car. But I haven't done anything like chainsaws over my head or fall on it that I know of. But it's sometimes it gets to the point that my whole arm feels like it's numb and it fatigues my whole body. So
Yeah.
like it just drains me sometimes.
Yeah, and then so some interesting points there, and we'll keep that in mind when we talk about some other relative issues and body parts. We're gonna get into that shortly. So we'll talk a bit more and probably relate to just a bit as well. Yeah, some other thoughts, yeah.
I'm Tim. Mostly right shoulder, occasional left. It started maybe 6 or 8 months ago. Really sporadic. Sometimes I'll work overhead with no problems at all.
Right.
Seems to be the worst like when I'm reaching for something in the back seat. Didn't hurt at all just now.
Keep that thought in mind too. Really tough position for the shoulder.
Now I know why you guys all showed up, because all those things I said in the videos, you're like, yep, that's me, that's me, that's me.
Yeah, yeah. Yes, sir.
Go ahead.
Yeah.
Go ahead. You first, you have it, go ahead.
My name's Cliff. I don't know what I did. Pre-COVID, I'd work out 3 times a week and could, work out without any pain or any problems. And after COVID, I got off for about 8 months. But during that time, I began to feel just in my left shoulder, just pain sleeping, and finding, where my movement was limited, and when I'd reach up at certain levels, it would really hurt. I didn't know if I had tendonitis or what I might have had. So I began to start working out again, and I've been doing it, I guess, for the last 3 months, and doing different exercises, and it seems to be helping. But I still have some of that pain.
Right.
But we took a week vacation, and I was off, and it feels pretty good this week, maybe because I took a week off.
Right.
But I'm just trying to understand what could be going on in there, and what I could do to maybe stop it. Because I am definitely weaker in that shoulder than the other,
Sure.
And you said left side, Cliff?
left side.
And if you had to give me a pain number on average, how bad is it when it gets you?
Well, today, or what it used to be.
When it
Probably
normally,
on average, let's say, and maybe when it's problematic on average.
It just, when you hit certain points, I mean, I could be doing anything and it's fine, and then you get that one point, you reach out for something, pick it up, and it's like, whoa, it just dropped.
Yeah.
But, it's maybe a 6.
Okay.
When that happens.
Sure, right. Enough to stop, enough to get your attention.
Oh, yeah.
Yeah. Okay, thanks. Yes.
My name is Steve. I don't know if you guys have the ESP or something, but my shoulder was killing me last week, and all of a sudden I get this text and email, come to a shoulder seminar, I couldn't hardly lift it up last week. I said, well, must need to go, because I just got the email. But, I've had some, pain over the years, some calcium buildup in that ligament. They say it's like toothpaste, they scrape it out, and bone spurs. And so it comes and goes. But I noticed, in fact, I almost forgot to come here, and I was sitting on the sofa watching the news, and I put my hand up above my head, and I was doing this, and then when I went to let it down, I mean, it's like you gotta go real slow. And it says, oh, I got a shoulder seminar to go to. So, I guess it's calcium or, whatever the mechanism is, but that's what kind of happens, when you don't have that range of motion all the way up and down. If you leave it, if you sleep up like here, I mean, it's like,
So the ESP tempted you and the voodoo dolls are what got you.
yeah, well, I wasn't quite sure, so.
We've got some other superpowers too, but we won't show you those tonight.
Well, so thank you for those of you that shared a little bit, and I think that we got a feel, and for those of you that we didn't get to hear from, some common threads, right? A lot of reaching. Some people are traumatic. Some people are just, I'm not real sure, it's repetitive use. Some of you guys know exactly the history of things that maybe led up to this, and other of you guys, I didn't do anything. I'm sleeping, or I'm just doing normal day-to-day things that didn't used to hurt. But a lot of repetitive activity, overhead, sports, reaching this way, reaching that way. Anybody else that has something uniquely different that triggers your pain that we didn't already touch on? Hey, mine hurts when I do this, and nobody said that.
Sleeping, reaching, working overhead. Once it's overhead, it doesn't want to come down. Those are some of the common things again and again. Yeah. Yes?
Mine started about a year ago, and I went to the doctor, and it was about 9 and a half, and I thought that I was going to need rotor cuff surgery, and really didn't know anything about it. And he had me stand up, he had me do some things, and he just talked to me, he told me to raise my arms, I raised my arms, and he said, you don't have rotor cuff problems. And I said, what do you mean? He said, you would have never got your arms above your head, or he said, you wouldn't have got them above your waist, had you. But he said, I can give you an injection, cortisone. And he gave me an injection, and he told me that, he said, it's different on every person. He said, don't ask me how long it's gonna last, or is it gonna work or not. He said, it's different on every individual. I said, okay. It lasted about 4 days. And I called him back and I said, can I do therapy? And he said, well, sure. And I don't know who I talked to, Michelle or.
Sherry got all your information.
And I had gone to Improvement Science.
Movement science, yeah. Mhm.
They helped me through lower back and a knee problem. Anyway, I went there, and it's basically the same thing. And to this day, 7 days a week, I do all the therapy ones that they taught me. And one of them that I dropped, and really I had to go back to, they'd have me stand up, your shoulders back, and you take your hand with a towel, press it against, and then press it this way, the elbow back and forward. I had to go back to that, and because at nighttime, that's when I would have the problem. It's just like one of these gentlemen said, I roll back and forth, one side and the other. And boy, when I go on that left side, and I'm left-handed, that's my side. It would hurt, but yet in the morning I get up and it would feel good. And then I do my exercises every morning. I found I have to do the exercises, 7 days a week.
Absolutely.
And what's your
So
name?
tell me your name.
Glenn.
Yeah, so what you're describing is not uncommon. And I'll tell you this, and there's a lot of good therapy places out there. Like anything in the world, right, there's good and bad of every profession. But ultimately, that is a common thread we hear again and again, that people are doing relatively well, and then they slack off the exercises, and then they experience some problems. Sometimes also there's this thing that, it's like a combination lock, for instance. Maybe you might have 6 of the 7 numbers, and doggone it, that lock won't open if you have the 6th, but it's at 7th number sometime, or just a little something extra. 6 things done right with 1 thing left out can leave you sort of a little volatile. So I've got this sort of philosophy when I'm treating people that I like to get on what I call on the other side of the fence. In other words, independent and capable, and keep those lines of communication open. So if that, again, you're in a good place that you could go back to some of these basic exercises and do well. but to make sure that the time and money and effort you spent to get yourself, to make sure that you're far enough along and you know enough about your problem that you become more independent at handling it. I don't need you dependent on me. The better you understand, and that's part of really what drives the reason behind doing this workshop. The better you guys, better you people, and I use guys interchangeably. Sorry, I don't mean to be, this day and age, we gotta be careful with things, and no disrespect to anyone intended. But ultimately, those our hearts and soul are in helping people get better, and it's about educating people. And again, sort of our intention tonight. Hopefully, you'll walk away knowing a lot more about your shoulders, and maybe kind of have a direction of, okay, what do I do from here?
And if you came just to learn how to sleep, we're gonna show you that later too.
Yeah.
Because that was on video, so we know it's coming. Steve, why don't you take a minute and we'll start onto your worksheets now, that number 1, what is the rotator cuff? If you could explain to them the model there and we'll kind of help fill in the blank with the model and the.
Okay, I like models. I think we learn. Some people are more visual than others. So we'll start with the model and then some drawings on the board here. But ultimately, this is your shoulder blade. This would be a right shoulder blade, and I know that because this little bony prominence is the spine of the scapula. So that scapula, this bone just hovers and sits over your rib cage. The scapula is the foundation from which the arm works, okay? The arm, this is the piece of the humerus that's there. And what we're talking about here is the rotator cuff. So if you look at your sheets, you guys have the questionnaire that's in front of you. I'm gonna walk you through and give you the answers to those questions. Ultimately, the rotator cuff, so it's rotator cuff, and it's a group of 4 muscles. You hear so much about rotator cuff. People will maybe call it rotator cuff or these other things, and there's a lot of confusion out there on what it is. And just basically, it's 4 muscles. And I want you to think, and it also, it's a group of 4 muscles, and the shoulder is also composed of joints, and ultimately, the cuff's job is to move the shoulder, okay? But I want to give you guys another little image, and Michelle's going to fuss at me because I'm deviating from the plan just a little bit, just quickly, because I think I like for people to get an image. We're in the South and we like boats, most of us. Or you maybe love or hate them. If you own one and it's a hole in the water you throw money in. But basically, I'm a terrible drawer, but if I draw a boat, okay, that sits in a dock, this is a dock here. Think of the rotator cuff as basically, it's not this simple, but I'll really simplify it. It's 4 muscles that hold a boat in the middle of that dock. Okay, and I like to give this visual because ultimately the cuff has to hold basically from 4 different angles to hold that humerus in the socket, which we'll get to the ball and socket.
So that's B on your worksheet.
Yeah.
The blanks there are the.
Yeah, so on A, the group of 4 muscles, and then it's responsible to move the shoulder. That's A. And then under B is going to be the next questions. The shoulder is a ball and socket joint. And the unique part about the shoulder being a ball and socket joint, this shoulder, this joint in particular, obviously, is very, very mobile. What makes it mobile? What allows us to, there's no other joint in your body that does this. The hip is similar, it's a ball and socket joint. But if you see me moving my leg like this, call 911. Okay, we're gonna have problems. That's a real deep socket, the acetabulum. It's a deep, deep socket.
We kind of use this as, you can imagine the hip socket is kind of like this teacup. It's a lot of bony surface, and the ball of the femur or the leg fits in there. So it's not gonna dislocate 9 times out of 10, but one of you guys mentioned a dislocated shoulder, or the difference with the ball and socket. I never have these on my initial eval with shoulders, but I always say it, and it's so nice to have this with you guys on a workshop, is say, the shoulder, it's great that it's so mobile, but the problem with it is you lack bony stability.
So this is the socket for the hip, basically. Think about it that way. It's deep.
And this is the socket for the shoulder. It's like resting a baseball on a teacup. If you didn't have those 4 ropes or muscles to hold the ball in the socket and evenly, right?
Yep.
You're gonna have a lot of popping, clicking, cracking, pinching problems.
And that, my friends, is the name of the game. Hold the humerus in the center of the socket, protect the boat from the docks or the docks from the boat, because what happens, now a wind picks up and suddenly this rope goes away. Where's this boat going? Against the dock. Either the dock's gone or the boat's gone or both. think of that of the rim of the shoulder and the surrounding structures. You're gonna have problems if this humerus isn't centered in the socket. Very intricate dance that happens day in and day out that we're completely unaware of. So, under C, these 4 areas work together during shoulder movement. So you've got 4 areas that work synchronously now. So it's not just a boat in the middle of a dock. We've got basically 4 major areas that are responsible or have to coordinate for the shoulder to work properly. We have the neck, we have the collarbone, we have your shoulder blade that I was showing you there. Picture the shoulder blade here that just floats in the rib cage, and then the rib cage. So neck, collarbone, shoulder blade, and rib cage. Fun fact for me, just maybe sort of a nerd with this part of it, but the shoulder, the only bony attachment to the body is actually where the clavicle or the collarbone attaches to the sternum. That's the only bony attachment to the thorax. So if you get rid of the muscle, the only place it touches bony area is right here. Pretty cool if you think about it, the amount of muscle it takes to hold that whole structure in place.
You win the prize. That was a great fun fact. I hadn't heard that at this workshop until tonight, so
I'm
thanks.
full of it. You know, I've got this and that, but I'll get fussed at later if I deviate. Sorry, guys. But I just think it's cool. We're passionate about what we do, and I think that when you're able to kind of look at things in that sort of way, it helps. It just helps give you that better understanding, and understanding means control. You can make decisions to better help yourself. So I think at this point, I'll tell you a little quick story. Did I have?
You can use this with your story. I mentioned the success story. Of
Yeah,
somebody you had
so
talked about. Kind of how the neck patients do. Sometimes they might, well, my neck, how does that?
Yeah,
How
so-
does that affect my shoulder? Or,
I'd like to share a little story with you guys, if it's okay, about what we do and a success story in terms of us treating and whatnot. Well, so there's a lady that came in, and she's having, actually, she has surgery scheduled to get her neck fixed. And she has shoulder pain, pain down the arm, some kind of similar things that I'm hearing, you know, across the room, some of these arm pain problems and things, and numbness, and very specific numbness. And she comes in, and I've treated her years ago. Matter of fact, we started off on Ocean Boulevard on this side of the lake in '07. On Highway 21, and I saw her way back then for another body part. Well, when she comes in and says, Steve, you've got to save me again. I'm scheduled for surgery. I've got 3 weeks to make a measurable change, or I'm having neck surgery. I said, okay, let's take a look at you and see what we can do. So as I'm working through the neck and taking a look at her and figuring out really what's going on and how we're going to approach things, what I'm noticing is her shoulder blade, as she lifts the arm, as we're doing these special tests with her, she lifts her arm, I notice the shoulder blade just standing up on her back. And we call that a winging shoulder, a winging scapula. When the scapula is designed in a way like we talked about, there's no bony attachments except for here, so we depend on muscle to hold that blade where it belongs. And those muscles not only have to be strong, but they need to be well coordinated to work properly. But the complicating factor is our spinal cord obviously communicates messages from the brain to and from the body. So if you've got nerve root problems, maybe from a disc, so this is a picture of a spinal segment, and you've got the spinal cord here. This is the bones on the back. When you lean forward, or someone real thin, you can see the bones down their spine. Spinal cord, and then nerve roots, and then the red is just the discs that we hear so much about. And when I give that little disc a squeeze, you can see it sort of puff out. Pretty interesting that the way it puffs out. And as it puffs out, it presses on that nerve root. And it's a pretty cool little model because it gives you a really good idea of what happens with some of these structures. Remember, the spine, the neck being a major part of the shoulder. So as I'm working with her, I realized that she's got a neck issue, but she's got a shoulder issue, and they kind of play back and forth with each other. In that her shoulder isn't working properly, so the muscles that connect up into the neck are working twice as hard. This upper trap, you know, how many times have we just had an upper trap that just feels like, man, if I can just get a pair of vice grips on it and just hold pressure on it, it would help. And what happens oftentimes, this upper trap commonly will compensate for other weaknesses. So what I realized is when I looked at that shoulder blade and realized there's other muscles that aren't working very well, I knew that upper trap was overworking. As it overworks, it compresses the spine and really contributes to the disc problems. So I thought to bring that story up to you guys because as I'm working with her to help her neck structurally, we do some traction and do some things on her neck to try to relieve the compression on the nerve root. If I don't work on the scapular problems, she's going to continue to have this vicious cycle that the upper trap continues to overwork to try to, the body's got to stabilize somewhere. And if you think about it, like we said before, if I get rid of one of these ropes, the rest, if they're intuitive enough, there's a brain hook to them, it's going to tell them, tighten up, do what you have to do the work of the one we've lost. But it's going to put more and more load on the rest of these. So, to get someone better, someone who has complications of neck, shoulder, nerve root, weakness, poor coordination of all these structures together, you've got to have the ability to look at things as a whole and to say, how do I prioritize and what do I go after first? How do we organize and prioritize our care? Because most people, as you can see, we'll go through a few things in a minute, that most people don't present with just one of the cuff muscles, let's say supraspinatus. There's just that and that's it. That almost never happens. There's usually layers of issues. And I brought her case up that now that I'm working with her, we're in the middle of the second week, she called the doctor and said, cancel my surgery, I'm not gonna need it. It's because not only we're working on the structural problems to help the numbness and tingling, but we're working on the issues that are contributing to that problem. Any questions or thoughts? Yes?
Why couldn't the doctors see that?
I have a good answer.
Yeah.
That really takes me to my next segment.
That's a perfect segue. And so I didn't pay him to ask that question, but it's a perfect segue.
And we won't take that because her primary complaint was the neck pain and the numbness. So they looked with their blinders on at the neck. But then she came to us from a PT standpoint. What is a PT? If you ask the general public what's a PT do, now those of you that have been to PT, you kind of already know, you're biased. But our job as a PT is to really understand the mechanics of the joints, the muscles, the nerves, the ligaments, and I can't just look at the body part that's painful with blinders on. I have to look at what else is contributing to that neck. You know, the upper trap runs from the neck to the shoulder blade. He was looking at what's going on in the shoulder blade and the shoulder mechanics. We don't just look at the one body part. So that's a really good segue. Yes, sir.
You saying trap or tract?
Trapezius. So is the upper trapezius muscle? Trap. Let's just
That
call it the
covers
trap.
what?
So the
Just
upper,
this section here?
the trapezius muscle, I'll use the muscle man as the model, right? So here's his shoulder blade and his shoulder. The upper trapezius attaches into the neck segments, and its other attachment is into the shoulder and on the spine of the shoulder. So you've got an upper trap, a middle trap, and a lower trap, and they all attach here. And so think about the rope model. If these muscles on her scapula are tight and holding, and this is tight and holding, it's compressing those discs. And it's also, she has shoulder pain and shoulder problems, it's creating impingement because the ball is not staying in the socket, it's jamming up and pinching the rotator cuff tendons, the bursa, and it's creating an inflammatory cascade. So to the question of why didn't they see that? Well, the good news is they sent her to PT. Part of the reason for sending to PT is because they want us to take a good look at all the parts that are involved. They want a musculoskeletal analysis. Welcome, thank you for joining us.
I have a hearing problem. I can't hear in the back.
No worries. I have a talking loud problem, so hopefully we work well together. So there was an article, a research study that was done, and it caught my interest, and so I wanted to share with you guys the studies because how many of you already had an MRI or an X-ray? Just by show of hands. Probably a good 2/3 maybe of the group. A lot of patients will come in and either say, I don't know how you're gonna help me, my MRI said I have a rotator cuff tear. And to your point, if you don't walk in doing like this, that's a full thickness tear. You look like you're flopping like a penguin. You can't do anything with that. Well, I say that. There are some patients that are not surgical candidates because of other medical risk issues, and we end up having to help them return to function with a torn rotator cuff because their body wouldn't withstand the surgery. So we're used to working both ends of that coin. But the MRI study showed this. They took 100 people that had no shoulder pain.
50 years old and older.
50 years old and older, 100. So this sample size, you know, maybe we've got 20 or 30 of you in here. Imagine this is a room full of 100 people, 50 and older. And they did MRI and X-ray and...
Remember, again, 100 people, no symptoms, 50 years and older. Real important to know this, with no symptoms.
Of the 50-year-old group, how many of these that have no pain had positive findings for osteoarthritis, spurs, tears? How many 50-year-olds with no pain had positive findings on MRI and X-ray? That's a good guess. 80%. So 80%.
80% people with no symptoms, 80%.
And then I think they go up to the 60-year-old group. So as you get a little bit older, no pain, positive findings for these same things. If the 50-year-olds, 80% of them have these on their diagnostic images, what percentage at 60 years old?
95?
It was 90. And then I think they jumped up to, what about the 80-year-olds who are having no pain but all of this? Somebody said 100, it was 99%.
How do you find 80-year-olds with no pain?
That's a
They do
problem in
exist.
itself, yeah.
They do exist. I'm gonna tell you, sometimes they end up in here and they're the ones that have been exercising their whole life. I tell my kids, it's my motivation to exercise. I truly think it's the fountain of youth, but you gotta know the right type of exercise, and you obviously change your exercise when you start having some of these things for joint protection. So my other question is, if they're all positive for findings on MRI and X-rays, why didn't they have pain?
Beer.
Because usually it's the other parts that were freeing up enough motion, whether it was in the neck, the collarbone was moving nicely, the rib cage was moving nicely, the scapula was moving nicely, or kind of to Steve's point, giving up space so they weren't getting the impingement. What usually causes pain is the impingement, the trauma, the pinching, and there's a cascade of inflammation that happens on a cellular level. And so I think you mentioned you had an injection that lasted for 4 days. Well, why is that? An injection can be very helpful. And most orthopedic surgeons will tell you, okay, I'm gonna give you this injection, but I want you to go see the PT. And they're well-meaning, because what they mean is, I'm gonna calm down the chemical factors that are causing pain on a cellular level of inflammation, but if you don't correct the underlying mechanics that are creating that volcano eruption of inflammation, it's just gonna keep coming back. And he doesn't know how long, because how many times are you banging into those structures in a given day or whatnot? So I thought that was a really cool study that I wanted to share with you, and I think it goes back into making sure we're looking at the whole person and all of the different parts that are
So
moving.
you're saying that they didn't feel a pain because other parts of their body was taking up the slack? So
That's right. These and these are normal age-related changes that do not have to cause pain.
The
They're
miracle,
normal.
the miracle of the body is, I mean, as you guys know, is that it adapts to its environment. It heals itself as best it can. When it's put in the right environment, in the right situation, it's great at healing itself. And oftentimes, it's that one little extra straw to break the camel's back that puts us over the edge. It can adapt to a point, and there's a point that it needs help. And to Michelle's point, whether it's an injection and then suddenly it feels good, so somebody's kind of teetering, they'll have that injection and they can get away with things a little longer. Others, no, mechanically things just aren't going good enough, and it's held out as long as it can. Injection calms it down for a short period of time, and the stressor hasn't been removed, so the inflammation, the irritation's right back.
So you truly have to understand the underlying cause of the pain. It's not just the structural deviation that you see on an imaging. You want to come, what we do on our evaluations is we do our movement analysis. We look at the neck, shoulder blade, clavicle, test rotator cuff strength, all of the, in the ribs, how are they moving? And then we kind of look at, okay, these are the key points, the top 3 things that are underlying the cause of your pain. That's gonna be different than your pain, different than your pain. And some of the, how it came on plays a role, but really what's moving well and what's not moving well is identifying the underlying cause and will help identify the treatment plan. That's largely what's happening on the evaluation. And so the fix, whether it's exercises or the hands-on treatment, really should be geared at getting all of those parts moving together and then strengthening once the pain level and inflammation has come down some and we've freed up some motion. So the same is true, injections, medications, some of the topical creams, anything you're doing to alter the pain will certainly help temporarily because it's controlling that chemical cascade of inflammation, but it doesn't really get to the underlying cause. That's why it keeps coming back. And that's why the well-intentioned orthopedic surgeons will say, I'm gonna give you this, it's gonna help, but you really need to go see PT. And so when you go back and they say, doc, it helped for 4 days, or I took this medicine for a month and it helped, but it's not gone. Well, did you go to the PT? No. You know,
And back to that point where you guys asked, well, why didn't the doctor notice it? Maybe they do, but if you've been to a doctor lately, and I'm sure most of you have, their time is so limited. So that's where they've really come to lean on us in terms of painting the big picture. What's going on? How is this affecting that? What came first, the chicken or the egg? So that's where we specialize as movement specialists, to be able to look at things and say, okay, what came first? Sometimes I can't tell you what came first, but I can tell you which order to go back in and fix it. And can it, and is it fixable?
And I want to say the inverse is true. Sometimes patients come to us and they're so adamant, I don't want the injection, I don't want the medicine, I don't want any of that. But they're so hot, like a hot iron poker, that everything is so inflamed. Sometimes I have to call the doc and say, hey, is this person appropriate for an injection? Can we help them out a little bit? Because they're really not tolerating the exercise as well. They're kind of, their shoulder's a little too hot right now. Is there something that we can do? Or we'll work here on pain relieving measures until we can get to that point. And the other times, sometimes, I'm not saying that physical therapy is the end all be all do all either. There are definitely times where doctors will say, let's do this, put you on this medicine, get you over to PT, see if we can, by restoring the motion and mechanics, get you out of the way of surgery. But there are times where patients truly do need surgery, and we then get back on the phone with the doctor and say, hey doc, the patient was compliant, they did everything they could, we did everything we could. You'll be better prepped for surgery because your motion and strength and you already know what to expect and what you're doing, but sometimes surgery is indicated based on changes that have occurred inside the body that are not appropriate for PT.
You know, sometimes I wonder, I'm not much into pain pills and shots and all that stuff,
Right.
and I wonder if that's why I hurt myself worse sometimes. When I went to see the surgeon because I was having problems with my knee, first question out of his mouth was, how long you been suffering with this? And I went, not too long. He said, what's not too long? I said, 13 years. I had nothing but bone on bone.
Yeah.
There was nothing left.
That's right. So absolutely, it can be tough to know when to do what, whether it's meds, whether it's, are we trying to get over it for now, we're trying to prolong the agony, and there's a lot of factors that go into that, because obviously, like I told you, replacement, you don't want to have that too soon, because there's a shelf life for those things. But I'll use Michelle's conversation about injections as a segue of basically, who am I? Michelle talked a little about her experience and who she is. Why me? Why did I fool with shoulders? Well, I was intrigued over the years. I spent a lot of time. I'm 50 years old right now. I've spent a lot of time in the gym over the years, just trying to stay healthy. And of course, like anything, you know, when you get involved in something, I'm competitive, and I wanted to be strong and fit. And I worked out at a variety of different gyms, from just like health clubs to just hardcore workout places. And whether the guys are this big, or the gals are this big, or the you know, it's just swimmers, or whether it's like aerobic type people, it doesn't matter. What I kept seeing again and again, so I've been doing this, I graduated in 1995, and I started in inpatient rehab, working on people who had head injuries, strokes, I mean, really complicated issues. And then as I evolved, my education evolved, I moved on to like more of an outpatient orthopedics, and got into more of like a sports-based and geriatric-based, and really just enjoying people who are active and really look forward to remaining active. I'll say this, another tidbit, I'm gonna just really go all out tonight. The fountain, they said that this A guy came in and told me this one day, and I thought it was interesting. That he said, Steve, they found the Fountain of Youth. I said, ooh, I'm intrigued. Tell me more. Wouldn't y'all want to know more? You found the Fountain of Youth. The Fountain of Youth is actually the quest for the Fountain of Youth. Think about that. Think pretty cool, right? Staying active, keeping your body moving. I just thought a pretty cool little tidbit of information. But ultimately, all these people are working out big, small, good shape, different things. And the common thing I kept seeing over and over is people grab and rub their shoulder. What the heck? How can a muscular person have a bad shoulder? How can they have a weak shoulder? How is that possible? And of course, I'm intrigued with movement and body mechanics and that sort of thing. And that's really where my passion for the shoulder came in. Number one, it's one of the most difficult parts of the body to treat. What I found again and again and again is we'd have a shoulder eval. The front desk person would come back and say, we have a shoulder eval, who wants it? And you just see everybody kind of duck their heads. Not me, not me, not me. Because there's all these parts that you have to deal with. They can be complex when you don't understand it. I'll take it. And I learned a lot from a lot of good people. And what I realized is that you can have really strong, look, there's a guy that I know, kind of a country guy, probably 6'6", 300 pounds, and this guy could grab a tree trunk off the ground and basically pick it up and carry it. Never worked out a day in his life. And three of his four rotator cuff muscles were completely gone the day he had surgery. So you can have, but he had a heck of a lot of shoulder pain, but he still was very functional. So it intrigued me to know more. So that quest for me to know more led me through a lot of advanced training on the shoulders. And once I started and began to really understand the relationship between the shoulder blade, the neck, the control of the blade, and it needs to be in the right place, and the humerus and the cuff, and how it all works and acts and reacts, is what led me to know more about it. Then what I found is there's some statistics to sort of back up what I was seeing. So 20 years ago, what I know is that physical therapy wasn't very successful when it came to shoulder treatment. And so there's sort of a pie graph, and I'll draw it as big as I can for the people that's further in the back. That's supposed to be a circle. What they found was of people who sought care 20 years ago for physical therapy, 25% ended up happy and well. 25% of people ended up with no change. And then 50% of people ended up with just kind of maybe a little better, but really not great results.
No lasting change.
And ultimately, yeah, if you're going to spend your time and money and effort, it's got to be worth it.
Now, I'm embarrassed to hear those numbers because we've both been PTs for 25 years, and that goes back 20 years ago, so that takes us to kind of our schooling, graduated LSU Medical Center, and it was the cream of the crop that got into PT school. We studied hard, we graduated with honors.
And I worked around some great therapists who had their hands down when front desk came back and said, do you want to work with shoulders? And I correlate that to those numbers. And what I realized is the difference is when I began my quest to where I'm at now, I realized how little I really knew about shoulders as a new grad, as just a general orthopedic therapist. I realized how little I knew. And then what I realized is that now, current time, that of patients referred to what we call hands-on physical therapists, people with the therapist, and I'm not the only person in town that has this ability, but not many people do. So some people say, well, I've had physical therapy in the past, or maybe you've talked to other people with physical therapy in the past. That fell into one of those three categories of like, it was okay, didn't make it any worse, but wasn't significantly better. Now, statistics show that 90% of people who go to hands-on physical therapists end up better. huge difference, huge disparity between hands-on physical therapy and understanding what the shoulders are supposed to do. And we went on a mission and a quest to be the best hands-on physical therapist around so we can achieve these kind of results.
And a lot of our coursework has evolved to a lot more manual therapy-based stuff, that hands-on treatment stuff. And there are a lot more therapists trained. I sit on the advisory board for LSU's PT school now, and I feel thankful and blessed to be there. A little bit about myself is I don't do as much orthopedic, traditional therapy anymore. Like I said, they just picked me for the poster child because I was the only one willing to get up in front of a video. But I specialize in pelvic health now, which is a lot more to do with the pelvic floor and the issues that patients face, bowel, bladder, and sexual dysfunctions, low back and hip issues and stuff like that. Have never lost my orthopedic skills, and one of my quick success stories that I'll share is some of the patients that we work with are cancer survivors. And I still have a good friend in the community who's an orthopedic surgeon, and he called me one day and he said, Michelle, I have a personal friend of mine that I need you to see. And I said, okay, that was quite a compliment. Well, tell me what's going on. She is active, she's 54 years old, she works out in the gym, she gardens, she does all of her things, but she's having horrific shoulder pain. It's going down into her chest. She can't get her arm over her head, it's radiating down the arm. He said, but I've done her MRI, we've done injections, I don't think it's her shoulder. Okay, I'm intrigued, what am I gonna do? He said she's had breast cancer and she's had augmentation surgery and radiation and different things. He said, I really think it's scar tissue involving her pectorals and whatnot. I'm like, oh, great. So it's stories like that that ended up making me the shoulder expert, was somebody trusted me. And so I went to my skills of what I know, scar tissue mobilization. Remember we said that rib cage has to be able to move and all those muscles that attach the shoulder to the rib cage? When I ended up taking a look at this lady, she had a lot of scar tissue from where the surgeries had taken place involving those ribs, and she was not moving, that scapula was not moving. So I was able to work very closely with her on just the scar tissue and free up the motion. And you would think that I hung the moon, because the woman just, her face changed, her demeanor changed, she lit up again. She got back to gardening, she got back to working out with her personal trainer, and she's been to us here. If she could show up at the workshop, she's volunteered to come and be like, I'll be your success story. But she's come a number of times for different things, and I just, I'm thankful for patients like that, and I'm thankful for the trust in the community to be able to help sometimes when it just doesn't make sense, you know, it's not the shoulder. But I thought we would take a minute and do, we call this a 5-minute miracle, so fingers crossed. Just find somebody who might be appropriate for this technique, that little hands-on, just kind of a demonstration of something that we might do that's hands-on in physical therapy, and see if it helps some of you. So I'm looking for a certain movement pattern that I think would fit this technique. So with your cooperation, can I get you guys to do some movements for me, and then I'll look and see who might be a good candidate, and you can help me look for elevation or rotation when they're on the same side. I know you guys have some shoulder pain and limited motion, and I promise I'm not trying to make you a patient, but if you would, and you're willing to volunteer, would you mind just raising your shoulders up overhead and show me what your motion looks like? Okay. All right, good, and down. And then if you would, turn your head over your right shoulder. Good. And then what about over your left shoulder? Okay, good. You look like you might be a good candidate for this technique in the red shirt. How do you? If you're interested. Trauma, you're the one that had the falls and some trauma back in the day. Yeah. What's going on with it right now?
Reaching up, then can't bring it down.
Okay.
I
Would you be
also have
willing?
a neck issue, but that's from hockey also.
Okay, this is old stuff. It's nothing that's kind of.
There's 2 chips in the neck and
Okay. Well, this is a safe technique for you. So if you're willing to volunteer to
it won't make me pass out.
I will. I hope not. Okay.
It looks so bad, right?
If it does, we have AED in the back. I know CPR. Let's not go that route.
Oh, yeah, they're fixing me.
If you would come up here and let's demonstrate. Yeah. So before you sit, I don't want to mess up your knee too much. Sit down, sit down. Show them your motion so they can see what I saw. Yeah, it's pretty limited there. And then
If I reach past that, I can bring it down.
Turn your head over your right shoulder for me.
That's it.
It's also pretty limited in that rotation. Would you mind turning your back to them? Because there's one more motion, I think. What's your good hand? Which one's the good
right
one?
one's the hurt.
Okay, so take your left hand, and I really like your striped shirt, because this is gonna help me out. Can you raise your shoulder up and try to reach between those shoulder blades? All right, so he's about to that line. All right, try this side. Okay,
That's it.
pretty limited shoulder. All right, I'm just hoping, here's what I'm hoping for. I'll do a little manual therapy technique where we use your muscles and your breath, and I push on you a little bit with my hands-on technique. What I'm looking for is any of that motion to improve in any direction.
I'm gonna warn you, if you don't get better, she gets very angry. So just
No, 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 I just don't get paid, no. Or your pain to go down with those motions. Fair enough?
Okay.
All right, so your pain level when you're doing those now, when you get to end range, what would you say?
I'm gonna probably 6 head and go over.
All right, go ahead and have a seat, and I'll tell you what we're gonna do. All right, so it's the right side is the bad side. Okay, I'm gonna put a little pressure here. Does that hurt at all as I do that? Okay. It's a little tender spot there, though, huh?
Michelle, do you wanna have your mask on while you're in proximity? I just think, sorry guys.
I've had my vaccine, so but I'll put it on just to keep you safe, so I'm not breathing in your face. Okay. What I'm gonna have you do is I'm gonna actually have you move your head and do some pushing against my hand, okay? So you'll push your head into my hand this way, good, and release. Painful?
Here.
Okay. So now tilt your ear towards your right shoulder, good. Take a nice breath in, and on the exhale, push into my hand with your head. Gently, good, and release. Take your ear over to your right shoulder a little bit further. Good, nice deep breath in. Push into my hand and exhale. Good, and release. Okay, ear over to your shoulder as far as it wants to go. Nice deep breath in. Push into my hand and exhale. Good. So that was about 3 reps of that. You didn't pass out, so that's the first good sign. All right, go ahead and stand up. I don't know if it's gonna be any better, but you guys can help me judge. You can tell me if it feels any different, but go ahead and raise your arms up again.
That's a lot better.
And down. Turn your head over to your right shoulder. Still a little stiff. All right, turn around, let's see what the line test shows us. So where were we about belt line?
A little higher.
That's
Yeah.
okay.
At least 2 lines.
At least
All right.
Ah,
I'll pay you later.
much higher.
What is the
Much
pain
higher.
level? Stayed about a 6 at the end
A 6,
range.
yeah.
So I said either get the motion better or look at the pain coming down, one or the other. He left, he didn't get to see my good results, so.
Another good result, huh?
All right,
Yeah,
have a
thank
seat.
Good work. Good
So,
job.
so what was that? What did we do? What was I pushing on? Do you know what I did was a first rib mobilization. So you remember we're talking about the trapezius muscles? You've got some different muscles that attach. So you have the perfect combination, limited neck motion and shoulder motion on the same side. That I knew those muscles that attach from the neck and the shoulder, all I did was a little muscle energy technique using your neck muscles, and I mobilized that shoulder down, the first rib down. When that first rib comes up, it puts the rotator, the brachial plexus, the nerves to that area on tension. It grabs that. All I did was free up a little motion in your ribs to free up the neck and shoulder movement. All it did was create a little space before you hit that impingement point. Okay, now if we gained 10 degrees with 3 reps of that, you've got about 70 more to go, 70 degrees more to get where you need to be. Imagine if we started cumulatively adding that up 2 times a week, 3 times a week, and then showing you ways to maintain that. That would be one of the first things I'd want to do for you. And that first rib mobilization usually works good in here because we usually see that movement combination. So thank you for volunteering for me.
Michelle,
Appreciate it.
I'm curious, is he predominantly right-handed? Is that the side he's got the problem with, or?
Well, I don't know if he was
I'm right-handed.
You're
right-handed.
right-handed, it was your right side, right? Yeah.
Yeah. And you know, is there a correlation there? I did see a lot of rights on that list, and probably the majority are right-handed. Is it just because it's repetitive use? Is
Well, I
it
noticed
your
when
dominant side?
people were identifying shoulder
Mhm.
problems, you had right and left.
Yeah,
Mine's left, and I'm predominantly left-handed.
Yeah.
And that's what he told me, he said, yeah, that's.
that repetitive use, that wear and tear. And so what we look at are the causative factors. What are the age-related changes? What are the occupational or sports-related stuff? What about the history of trauma? What does your work require? One of you guys said about the iPads, you know, different things like that.
Yes,
So,
ma'am, do you have a question?
I can't lift my arm at all, unless I use this hand to lift it up. I work at Sam's warehouse, and I tried to pull it loose 2 buggies,
Right.
and it didn't come loose.
Mhm.
And it just,
So-
for like a month, I've been in pain.
Yeah, and that's a good example. So we would take a look and see if there were some certain red flags. There's a few things, and I want to move us on a little bit. I want to finish with this thought because I don't want to keep you guys past what we promised. I don't want this to go on too
and then
long.
the second half of this worksheet will go
yeah.
pretty quick,
Yeah.
so we can
But-
get you.
But ultimately, though, is like in this case, if I would do a test in that case of some red flags, then the nice thing is we've got some really good relationships with docs that we can get you in and fast track you in fairly quickly, unless you've got your own doc. We've got no under the table deals with any docs, but just docs that we've learned to trust over time that have really good results. So we would get you in, take a look at you, and then help you decide where do I go from here? How do I address these issues? Is it something that's treatable? We would
Would
make
I
that
have to
decision.
have an MRI first?
We will let the
we would-
doctor.
Yeah, we would start with a screen on you to take a look at you, and then we would recommend what direction to go. But you would not need an MRI before you saw us. We wouldn't treat you, we would just test you and then have a better idea of what's going on with you. Because everyone, as you've heard, can be very similar but very unique. So ultimately, but thanks for the thought on that. Ultimately, the theory is, and this is A, under number 3, that if your pain is reproducible, then it's reducible. Yeah. Yeah, if the pain is reproducible, then it's reducible. So, in that line B, you can answer the question, in the last 30 days, the worst pain I've had is, if 0's no pain, 10's the worst imaginable, then rate your pain, the worst pain you've had over the last 30 days, and if you would, answer that question there. And then beneath that, under C, we've talked about some of the common themes, and then so circle some of the things, some of the actions that increase your pain. We talked about reaching into the back seat, maybe fastening a belt, drying your back, fastening a bra here again and again, sleeping on that side. Under 3C, lifting, carrying objects, reaching overhead. There's a variety of things. So circle the things that's common for you that reproduces your pain. And again, keeping in mind that if the pain is reproducible, then it's reducible.
Question for you.
Yes?
Yeah, I can circle all of them, but it's different pain with each one of them.
Yes. So different actions are happening. If you remember, the way we discussed is that depending on what action happens and let's be specific, very shallow socket, very mobile ball and socket joint. So depending on what action, remember, for every action is equal and opposite reaction. So as I reach, the humeral head tries to move in a direction. Depending on what it's impinging on, what it's stretching, what it's smashing in different angles is the reason for the different pains. Or compression, laying on it, having it compressed to the wrong position. That's what gives you this variation of pain based on the stimulus. Make sense?
Mm-hmm.
Really good question.
Since we brought up sleeping again, I know that's the main reason you came, you want to know how to sleep. I'm sure a lot of you, right, sleeping is a problem. So what we know about the shoulder joint, so it's that ball and socket, there's a capsule that holds it together. And when you're sleeping on your side, if this is your painful side, you're not only putting your body weight through it, but you're compressing it in a closed pack position. We call it a closed pack position, is where there's the most bony contact, and there's not a lot of good movement for blood flow in there. So your best way, and this is what we teach our post-op shoulder patients, is you're gonna take just a regular pillow and about midway, shove it under your armpit. And if you're laying on your good side, this would be your bad shoulder. It opens that joint, an open pack position for better blood flow, oxygen, nutrients. And nighttime is typically when you're trying to heal. And
Have you
if
guys
you're-
seen people in post-shoulder surgery? How do we know they just had surgery? What do you see them in, a sling? What position is their shoulder in the sling?
They've got that little bolster, and that's why, for blood flow and oxygen nutrients. So if you are a back sleeper, you just wanna make sure this is under your arm enough, because if you're on your back, typically that elbow rides back and it'll close it off.
Yep.
So here,
As her arm goes back, the humerus goes forward and
Impingement.
causes impingement here. So
So
to
on
make
your
sure to
back,
her point,
yeah.
she's supported there.
and
Well, she had two bad shoulders.
then you gotta lay on your back with a pillow under each.
Yeah.
And that pillow there keeps you from
I do.
rolling left
Yeah.
and right.
Yeah.
And then when your back bothers you, you put a pillow under your knees too, but we'll save your back for the next seminar.
Yeah, but to have pillows under each, same thing, to get
Yeah.
your both shoulders in that position. And so either on your back, to Michelle's point here, or semi on your side with a longer king-size pillow behind your back, semi-reclined that way
And
with
a
a
lot of
pillow here.
patients end up sleeping in a recliner after surgery for the first 2 weeks or three. You know, we had one patient that the main reason he came in was he was dealing fine with his shoulder pain. His wife was mad that he wasn't sleeping in the bed anymore. He was sleeping on the recliner. So he said, "I need you to save my marriage." My wife said I have to sleep in the bed. So, but this helps whether you're driving and your arm is out on the armrest or you're sitting on the couch, keeping it out. It's just a pain relieving position. And, you know, I think that takes us to kind of as we start to pull it together and
So any questions about sleep-in positions? I think really important. It's a gem of a piece of information. Like Michelle said, post-surgical patients who are really in a lot of pain, they usually come to us between 2 and 4 weeks post-operation. One of the biggest gifts we give them is the ability to lay back in bed again.
and hope to be able to give you guys that gift tonight, that you sleep better. Try out this technique. You're like the princess and the pea the first night or two, pillows are in the way and you're like, but just keep sticking with it and you'll start to get some relief and be thankful for, starts calming down that chemical cascade of inflammation.
Don't sleep on that arm at all.
It's best to avoid sleeping on that side. It'll wake you up and tell you to move because it's not good for you.
And
Is
that's
that
how I
the
know.
same-
Yeah, sorry.
Is that the same thing like when you hold your arm up like this for an extended period of time? and you
Closed
go to
pack
put it down,
position.
It just impinges on
Yeah,
it?
that's right, that's right. So, and by the way, one of the benchmarks for me when I'm treating people is they start telling me, I was able to sleep on that shoulder for a few hours and it felt fine. Then I know we're crossing that fence. Yes, sir.
Can you wrap something around your arm so that pillow doesn't move around? Because I switch back and forth to sleeping on my back to sleeping on my right shoulder.
Right.
And if I don't have that pillow wrapped in something, it's just gonna fall.
It's gonna
off.
wait. I'm working on a Velcro suit, some kind of way we can Velcro it. I don't know. We'll have to talk after and see if we can put something together. But you're right. I mean, the problem is once you're asleep, all bets are off. So.
I sleep with a knee pillow in between my knees and that
Yes.
helps a lot.
That absolutely, and that's why I suggest the king-size pillow or, bigger pillow behind your back, so it acts as a wedge, and it'll at least keep you positioned for a while, but inevitably, though, we're gonna move, so it's tough, and, good
We're
point.
coming close on time, y'all. I know you guys probably have family and things to get to, and so do the ladies up front, so I'd like to get you guys through the rest of this worksheet.
Yeah, so the number 4, the biggest mistake that pain sufferers can make is they ignore it. So that's question number 4, they ignore it. And then the 3 things you can do about your shoulder pain. So what are the things that you can do right now? You can either ignore it, alter it, or handle it. Ignore it, which we know is just pretend it's not there. Do nothing.
Alter sometimes means just relying on the meds.
Or use the other arm.
Or changing how, don't reach anymore, just move your whole body. That works short term, but it's not gonna get into the underlying cause.
And I had a thought earlier, is that we talked about normally our dominant arm is the one that hurts, and we form these dysfunctions, and then through overuse, it starts to hurt. But a lot of times we see that the right arm is the dominant, and it's hurting. Now I start using the left, now suddenly the left arm starts hurting. It's because that's the arm that starts moving. So I think we're on to something here, that it's just that overuse that causes the problem. that when mechanics aren't working properly. So, and then handle it, is the other part of it. So, the top 3 common causes of shoulder pain, as we discussed, is neck pain, like the lady that I was treating in the example. Problems in the neck. Impingement, where the shoulder blade doesn't live where it's supposed to, or the humerus drifts forward and causes a pinching of the tissues at the front of the arm. And then C is poor posture. So we've got a quick demo, and I'll just show you guys, and you can try this on your own for time-wise, because I want to really, we're going over a bit. Michelle and I do talk a lot, but I'm mostly the guilty one. I'm sorry for that.
It's usually me.
But if you guys can try this on your own time, because I don't want to steal too much more of yours, but if you bend forward with bad posture, so good posture, shoulder moves fine. I've got healthy shoulders for the most part. I don't get into that, but ultimately if I bend forward and really exaggerate poor posture, now the arm doesn't move. It's because it locks up, it puts it in the bad position, and it doesn't allow it to move. So poor posture plays a huge role. And when I say poor posture, it's not just being forward, but where the scapulas are positioned, a key part of what we look at for treatment.
And so number 7, what does successful, non-invasive natural treatment look like? A is hands-on PT. You guys saw that one 3-rep movement and the difference it made. We would pair together a lot of those different types of hands-on treatments to get better movement and results. So hands-on PT to move the shoulder and the surrounding joints. B is strengthening exercises to retrain. Steve talks a lot about just the muscle memory. You know, you guys are getting your exercises today, and these are the top rated exercises for strengthening the rotator cuff. The problem with getting generic exercises from a handout or YouTube or my friend is a PT at the gym, whatnot, is that the best way to go about it is to do the exercises that you need at the right time to facilitate the weak muscles, to inhibit the overactive muscles, and to target where your individual limitations lie. And that's what PT is about.
If I have your permission, I'm going to give you just a quick example of that. I have Miss Peggy that comes in. She's a bit taller than me. I don't know if I'm sure you've seen her in here, I'm not sure, but I won't say her last name, of course. But ultimately, she asked me, Steve, why is this taking me a little bit longer than most? I said, because you needed therapy to get to the starting line. And then therapy starts at the starting line. I'll tell you, what do I mean? What does that mean? Michelle's saying, and this fits so perfectly with this, to make this point, is that for a row, why am I doing an exercise like a row? Remember, I'm trying to retrain the scapula to be where it's supposed to be. Typically, we work here at the computers. We're so forward and rounded. So I had this lady, and I showed her a row. So I gave her a piece of TheraBand, the row, and what I watched her do, she's a taller lady, so taller people have a tendency to stand with forward posture as well. For little short people like me, they don't want to be too much above me. So I saw her do a row, the arms move. Look at this. Look at what's happening. This shoulder humerus is doing what? It's going forward. It's impinging on that bony structure, biceps, pecs. So she's doing the right exercise, but the wrong form. So guess what's happening? She's going backwards. Start line's that way. You're going the wrong way. So what I had to start with is grabbing that band, and I had my hands on her shoulders, hands on PT. Now let's just get the shoulders doing this. Damn it, why don't my shoulders do this, man? What's wrong with me? So nothing, Miss Peggy. Your beautiful things are gonna go great. Here we go. Next thing you know, I just started with getting those shoulders moving back. Put the band away. Just get in the mirror. Let me show you what this feels like. Oh, gosh, I feel so much better. That's my story. I just wanted you to know that it could be the right exercise, 6 of the 7 numbers, but not quite that last one. Critical.
So B is strengthening exercises to retrain muscle memory, because when you're in dysfunction and pain, your body starts moving and all it's going to remember are those abnormal movement patterns. And then C is pain and inflammation relieving modalities. We invested over the past year in a light force laser. Steve and I have, with 25 years of practice, laser has come in and out of our practice with diabetic neuropathy and other things that are proven in the research for it to help. But one random year of Medicare cuts and laser stopped getting covered by insurance. It was proven for wound care and diabetic neuropathy and all these things. We went to a course, and it was a shoulder and knee course, and there was this big, huge laser in the back. And we went and talked to the rep and said, who's buying this? Like, I know what that machine costs. It was a lot of money. And I said, insurances aren't even paying for that anymore. I said, why are you here? I don't understand. And he said, no, colleges and professional teams still buy our lasers all day long and use them on the field because they're actually losing money when their athletes are not on the field. And I went, huh. I didn't buy one back then because I couldn't afford it. But fast forward, and we decided to invest at this site.
So I'll tell you real quick, I'm a semi-professional red fisherman. One day you might see me on TV. I have been, but on the high channels, like in the 600s, okay? So I fell off of a 6-foot platform. I was fighting a redfish, fell off the platform, and my shoulder almost pulled it out of socket. I caught the fish, by the way, and I went in, saw Dr. Rowling, and yep, you know, you've done some pretty nasty things. I couldn't lift my arm past here. This guy comes in and demo the class 4 laser, does the laser to my shoulder. Wow, this thing's moving.
One treatment.
So.
And it wasn't the end all be all do all. It calmed down the inflammation.
So now, it was so bad that I couldn't treat it because it was so inflamed. And the questions earlier, sometimes we'll use an injection, if they're appropriate, we'll recommend an injection to calm things down so we can do some therapy. The class 4 laser is a tool that we have in-house that we can use to also help with that. So,
so sometimes we'll do a trial early on to see if you're a good
Excuse me, when you said C, you said pain and what were the other?
Inflammation relieving modalities. All right, so it takes us to a close. When these ladies walk up, they're like, all right, guys, you're over by 10 minutes. It's time to go home. So in closing, I just have one question for you guys. How many of you, by a show of your good hand, are going to leave this seminar and continue to ignore it? Ignore it. Good answer. Because I would hope at some point to be able to see all of you guys. It truly is what fuels our passion, is helping people get better and get past their stuck point. So how many of you are going to continue to alter it with pain meds, injections, topical creams, change how you movement? How many of you guys are ready to handle it? You know more. You're ready to get started. Now it's like exciting almost. Like, wait, that might even work. Okay, so I expect to see every one of you guys in here, either working with him or some of our other shoulder experts in here. Candace did get with me today and asked me to open up a few spots on my schedule for Friday because they were fully booked. So I know that I have some spots on Friday where I can...
Well, so spots for what? What we offer is a free screen. If you guys are on the fence, I'm not here to sell you anything, quite honestly. We love what we do. We're passionate about what we do. For the few of you who's been here and understand who we are, we'd be interested to take a look to see specifically with you if there's some things we can do to help you or recommend what is it that you can do to help your shoulder. You've got some good sleeping instructions and that sort of thing, but ultimately a free screen, absolutely no obligation, no pressure.
Examination is really a 15 to 30 minute meet with a therapist to discuss individually the nature of your problem and for us to discuss what we think the underlying causes might be and what a treatment plan would look like. There's no financial insurance obligation, none of that. If you decide you want to go ahead and schedule an evaluation, these ladies are happy to take any insurance information, verify benefits for you. If you're ready, if you're like, hey, I need an evaluation, I don't want to waste my time on an exam, they can take care of that. If you do the exam and you feel like you're confident with where it's going and you want to then go on for an initial evaluation, no problem. We're here to offer you, I think the general public just doesn't have a good idea of what PT is all about and what we do, so I hope we answered your questions.
No, I'm saying, well, you did.
Oh, good. And what about you?
I'm just curious, do you have to be referred by a doctor?
You do not need a physician referral. Insurances that are government, Medicare, Medicaid, TRICARE, these girls can answer those questions. Do require physician referral, but they are also happy to find out who, maybe your primary care, or if you've been in the care of an orthopedic, or if you need us to send you to somebody because you need a referral. They will help that coordination. You guys should have a checkout sheet that, since Steve ran his mouth too much, I'm gonna blame him. You can write down your contact information if you don't have time to stay, because we usually say that people that are in the most pain, 7 out of 10 pain on that list, to go first and take, you know, the appointments that are there first.
If you can wait till next week, if
But
it's not urgent.
give them your sheets of paper, and Sherry, that's been in touch with you, will, if you guys need to get out of here because we ran late and it's starting to get dark, you don't want to drive after dark, give her your piece of paper and say, call me, here's the days and times I can come. If you want to stay and schedule, they're more than happy to get you on the books. But thank you, everybody, for coming. What a wonderful group. Glad to
And if
see you.
anybody has any questions, feel free to
We'll
ask them.
stay back to answer any questions. questions.
I have one.
Yeah,
If I'm already coming here, do I still, you want me to still fill out this sheet?
no, unless you think it would help your therapist.
No, I already know. I tell them-
You probably told him all those things already.
I told them everything they want to hear from me.
And thank you for the compliments. I don't know that I've seen your face, but usually after I do a workshop, I try to come around and see who's in here and.
I'll say this.
All right, we're gonna go
I'll
back.
come here sometime and my arms a little stiff, and when I leave, I feel so much better.
I
That's
love
the
it.
only person that had a problem finding his
And everybody who's worked with me.
I've been here before, so
Steve, you seen me here. I usually
I
come
was
here
on
twice a
the
week.
state.
That's
it's a well-kept secret.
Going all over.
As long as
Took
you
an hour and a
man
half.
keep saying, okay, go ahead.
Totally. Well, and we want to make sure that we make good use of the time that you do have here if it's an approval thing.
Well,
to
They
achieve
do
it.
a great job.
Yeah.
Awesome.
So,
I can take someone if you guys wanna come and chat and we can
well, I
maybe get you scheduled for a
I
break
rated
in.
you, put the thing here, but I didn't.
Perfect, I'll
Hey,
take that.
maybe you can go
Nice.
on the Facebook page and talk
You know
about what you
Let me
learned at the
Let me tell
workshop.
you something about me. I've never been on Facebook in my life,
Oh, God bless you.
and I have no desire to send it to them.
Thank you, sir. A
I can walk you
packet,
guys to
the exercises,
No, we're good.
the worksheet of your information. Yeah, I think it's this, but let me go ask Sherry. Earlier today, when Sherry, it's usually the worksheet, the exercises, and your checkout. She usually she'll mail that to you in the mail. You're welcome, packet. And then it's to put in your exercises. Well, let me go ask her. Let me go ask her. You asked Jerry about it already? No. Okay, let me go ask her.
It didn't bother me in the surgery, except for the monkey bars and the pain. And I was double over in pain, pulling on my shoulder. Because I had to get the Now, I have a hip replacement, they rolled it, it's pinching me, even now, just from sitting. Right now. In fact, when I do the adduction and abduction on the machine, the ones when I push it out.
Have a good, I'll see you tomorrow.
All right.
Just from sitting, just on the ground. And then my knee, I had the knee replacement all the same day. Every now and then you get a raw feeling, the doctor will have some testing, and he thinks it's not quite precision fit. And you got some blood
Hey,
activity
Steve.
nerve, pain.
Steven? Back there.
Any questions at all? Are you okay?
Hit the rib out.
Oh,
No, because for you,
Yeah.
that hip, you might have a little scar tissue, we may need to work that out a little bit. I mean, that could be
That's what
short,
they did on
that could
my
be
knee.
short and sweet for a big difference. If that keeps bugging you, you need to let me know about it. I'll knock that out for you.
a lot of times, one of the things that I feel is like, I feel like something popping or catching or whatever.
Right.
Okay, when you're talking about the muscles and stuff in here, if it's right here, like, what is that?
So, popping can be a variety of things. You've got on your bones, obviously they're just not slick smooth.
Yeah.
Right, you've got greater tubercle, some of these bony prominences, grooves and whatnot. This is the bicipital tendon. And what'll happen is sometimes you'll get, as you move, if it's with movement, sometimes if this arm, the humerus, doesn't stay where it belongs, sometimes you'll get some popping as it runs across the labrum or the tendons. So oftentimes that'll cause that popping. Sometimes you'll get a clunking as this humeral head. So it looks like as you move, the humerus kind of gets stuck, and then as you come back, it'll kind of.
Yeah, okay.
So there's a variety of things that happen, and ultimately is like I drew the boat between the
Yeah.
dots, crude drawing, but you get the idea that if that humerus, as I challenge it, and what makes it challenging is the scapula also is not static. It's designed to move to a degree. It's like a 3-to-1 ratio. For every 3 degrees of humeral, it's a very simplistic idea of or description, but it's nonetheless gives you the idea, for every 3 degrees of humeral movement, that you got 1 degree of scapular movement, up to a point that it changes. It goes 1 to 1 at a certain point, but ultimately, so the core, to get that foundation, when I look at a shoulder, I start with the shoulder blade. We test everything else because I want to make sure that there's no red flags, which will mean like, is there a significant finding? Is there a test, significant weakness that tells me that maybe there's some bad ruptures of the cuff? Because if you've got a full thickness tear of a cuff of one of the 4 muscles, we're going to have limited outcome. Let's face it. But ultimately, if there's partial tears on MRI and other issues, partial labral tears and other things, then we can work on that shoulder, typically position the scapula, get the scapula good and strong. Remember, that's the foundation. We build our house on the foundation. So once the scapula is strong, now the socket, the glenoid, is predictable. An unpredictable glenoid is a shoulder's enemy. So if I go to lift this arm, and instead of my blade staying flat, if it flips up off my scapula, now the glenoid, the socket, where's it going to be? Now we're having a guess. And chances are, once it flips and does this, bam, I just impinged.
Yeah.
So that's why when it comes to diagnosing what in particular is causing that clicking, is it the bony prominences? Probably, most likely. Is it some inflamed tendons maybe, which, you know, kind of compounds a problem? Now the tendons are bigger because we've got a given space, and hopefully I'm not going on too much, but we've got a given space. So if you look at the acromion, this bone right here, and that's right there, it comes right around the back. You know, as you can see that blade, if it's sitting, this is a smaller blade than mine, but it's sitting there, this bony prominence right here, the bicep, the pecs, they pass right under it. So if that humerus drifts forward, if you imagine if I put your finger under there and just pressed on it, man, that's not gonna feel very good. And now that's now raw tissues up under there. So the more it rubs, the more it gets inflamed. There's very little space to begin with. Now you inflame those tissues, there's less space, and that's typically where the pain comes in. That's where the docs will go in, hit it with some cortisone to calm it down, calm the inflammation down.
But it's not fixing the problem.
That's absolutely not. So it's fixing the symptoms. Now I need to get my blade back. Sometimes even you'll form a spur at the end of it, so that's less space too. But I can even help most people with that. Some people, the spur's too big and they've got to go in and do what's called a subacromial decompression, where the doctors will go shave the back of that thing and give you space. But most of the time, by working the muscles, I can pull the blade back. There's also muscles that run up under the blade like this. That's what keeps it from flipping up off the rib cage. So if I can get it back where it belongs, and then through the rotator cuff, pull that boat in the slip, or pull that humerus back on the glenoid, now we're giving it space. Because gravity can be a beast. Once that blade's flipped, now the humerus just wants to hang forward. Look at it, how many people you see walk around with their arm, I mean, I'm exaggerating, their shoulders forward, right? So now, so the best thing, what's the best piece of advice I can give you? Get those shoulders, not just shoulders back, but chest up. Getting that chest up, now gravity's helping you rather than hurting you. So pretty cool stuff. And the results, it's amazing. Because, before I was seeing what got us doing this seminar was people would go to their doc, they'd go get an MRI, go get an x-ray, maybe get an injection, and then, well, let's just wait and see how it does. And then 6 weeks later, the problem hasn't gotten any better, it's worse, people are frustrated. Well, maybe you need surgery. No offense to some very good docs who know us well and who says, shoulder hurts? They may do an x-ray just to make sure. If there's some red flags, they'll do an MRI. But at the end of the day, or if your shoulder's really hot, yep, let's inject it. But go to therapy. It's gonna feel better, but you gotta be smart on that. Go to therapy. So, that's why we started this seminar, so I can grab people like you guys off the street who haven't been through that rigmarole yet that says, yep, I've been dealing with this a while, and it's relatively simple. Really relatively, when you know them, like anything, right? I mean, my grandpa was a locksmith. I don't know how to pick a lock or how to change a lock, but boom, he could get that thing done, no problem. Rekey it and whatnot. So it's what we do, so it's really relatively simple. And it's also simple, and I also have this philosophy, and I should have mentioned this, and most of the time I do. We've got a philosophy around here that it doesn't have to hurt to help. Normally, if it's hurting you while you're doing it, you're doing something wrong. Use that pain as your guide. So You try to do a few of these exercises and you feel pain, shut it down. Your body's telling you no, because there's this old mentality that says no pain, no gain. That's just the furthest from the furthest from our philosophy. You know, your body's saying, hey, cut that out, I don't like it.
Yeah. But you all come highly recommended. My daughter uses your Amanda Lindsay. I don't know if you know her or not.
Yes,
She's, therapy for the CRPS.
yes,
And so she's going through a difficult time right now from a little whiplash situation, but she's getting better. And so hopefully in the next couple of weeks she'll be back. But
nice, yeah,
my wife saw this and said it's a great opportunity and all that. So
yeah.
one last thing I'm gonna ask you is that, okay, like you're talking about bringing the hand behind you to bring it up and all that. I find that I get pain here when I'm doing that.
Right. So remember,
I'm not getting the pain in the shoulder, it's in here.
so I'll tell you this, and this hopefully will be an aha moment. I like to lead people to their own conclusions. When you've surely smacked your funny bone,
Oh, yeah.
and when you do, where does it hurt? Here, but also here.
Yeah.
Right. Oh, numbness, tingling.
Yeah.
If you hit it hard enough for a couple of days,
Yeah.
it's aggravating. So that those nerve branches that start at the neck, brachial plexus, run through here, under the blade, through here, down the inside of the arm, and they branch off a couple times and make their way down. So ultimately, is when you impinge and you get yourself in the wrong position and impinge on those nerves, probably a little bit of inflammation, so there's less tolerance, to movement, less. So ultimately, you get yourself in a bad position. You just kind of catch those nerves a bit, and that's what gives you that radiating pain down the arm, the impingement in the shoulder.
Yeah.
It's
It's here, but it's feeling here.
Yeah, exactly.
Okay.
So it's a radiating pain, no different than that funny bone. I like to give people real life examples because, like, man, how is that possible? Same thing. You smack that funny bone, it lights you up. You impinge the nerves here, it lights you up more proximally.
Okay.
Yeah, and most people come to me like post-surgery, oh man, I'm fine here. It's right here, I'm hurt. It's coming from your shoulder, no worries. And they even get sort of a lump, from the lack of movement. So I'll work it out for them and get it moving. And next day they come in and want to kiss me. That's not necessary,
So, a couple of years, about 3 years ago, 4 years ago, I stabbed myself. Severed the tendon and the nerve to this finger, so I can't bend the tip here.
Right.
And all that, but the tendon, was going through therapy and felt a pop, and when that pop happened, I lost this. Because before, I was able to even do that with this hand.
Right.
Now I can't.
Right.
So that here, does that affect this too?
Maybe to some degree. Your body always tries to accommodate, so it's possible. Your body's looking for a way to make it happen.
Yeah.
So you probably caught part of that intrinsic, the part that does this, the muscle just local to the hand. And when you did that, you had part of it with the knife already, and you probably just finished it off through stress.
Yeah.
So is it possible? I mean, I wouldn't say no, it's not possible. I mean, it could contribute to some degree. That weakness or dysfunction in the hand could to a small degree.
But I mean, damaging the nerve here,
But more or less from a biomechanical standpoint. It's not gonna refer pain back up, but maybe if you've changed your behavior because of this weakness some kind of way, that would be the factor, but it's not gonna radiate back to here. This isn't gonna cause the pain directly, it's more of an indirect from a behavioral standpoint.
yeah, because I'm right-handed, so this isn't the dominant hand.
Sure.
So, yeah. But, I'm not in any critical, who do I leave this with?
When you come right around, Sherry and Candace are both right over there, and they'll answer it, like I said, if you wanna, however you wanna take a look at it.
Awesome.
See what, we're here for you.
Thank you. Thank you
You're
very
very
much.
welcome. Good. You enjoyed it?
Yes, it was very informative.
Awesome, thank you. That's our goal. Look, I don't want to feel like I'm trying to sell anybody anything. I just like to teach them a little bit about what we do.
Just fantastic.
Good deal. Thank you. Thanks for coming.
Thank you.